بسم الله الرحمن الرحيم. هنتكلم النهارده عن practical tips for management of supraventricular tachycardia. وأحب في البداية أشكر جمعية القلب المصرية for such initiative. And this is based on the European Society of Cardiology guidelines for management of supraventricular tachycardia at 2019. ECG is sometimes not as easy as expected. As you could see here in this ECG, the patient was entirely has no symptoms with slight prolongation of QT. Then he had torsion de poids or polymorphic VT, which is one of the dangerous arrhythmia. So we have to take care of all details of ECG when interpreting ECG in emergency or even in the outpatient basis. SVT is classified to regular and irregular SVT. Regular ones include the sinus tachycardia, atrial tachycardia, atrial flutter with fixed AV conduction, junctional tachycardia, AV nodal reentrant tachycardia, and AV reentrant tachycardia, while irregular SVT includes atrial fibrillation, multifocal atrial tachycardia, and atrial flutter with variable AV conduction. This is how ECG looks for each tachycardia. In sinus tachycardia, it looks like the normal ECG with heart rate more than 100 beats per minute. In atrial tachycardia, P waves are abnormal, sometimes inverted in lead 2 or very close to the QRS complex and not as the normal sinus, which of axis of 60 degrees, and usually is very fast with sudden onset, sudden offset. Atrial flutter with fixed AV conduction, as you see in this ECG, with typical sawtooth appearance of 2 to 1 conduction. Ventricular rate is 150 and flutter rate is 300 beats per minute. Junctional tachycardia, where slow tachycardia somewhere between 100 and 140 or 160 at maximum. Sometimes no apparent P wave is there. Then we have AV nodal reentrant tachycardia, which is a very fast tachycardia. As you see here, heart rate is about 200 or 220. And as you could appreciate here, no clear B wave there. However, there is some sort of distortion of the terminal complex of the QRS representing retrogradely conducted P wave. Then we have EV reentrant tachycardia, again fast heart rate of about maybe 180 up to 240, and this type is the orthodromic tachycardia. Then we have irregular tachycardia like atrial fibrillation. As you see here, there is irregular heart rate without apparent P waves. Multifocal atrial tachycardia, where you can see at one lead polymorphic B waves more than 2 morphologies of B waves in the same lead. Then we have atrial flutter with variable AV conduction, where you could elicit the abnormal large B waves, which is not fixedly conducted between the atrium and ventricular channels. What should be done in supraventricular tachycardia? According to the guidelines, 12-lead ECG is very important. Vagal maneuvers, preferably in supine position with leg elevation, are recommended. Adenosine from 6 to 18 milligram IV bolus is recommended if vagal maneuvers fail. If patient in acute management of wide QRS complex in absence of established diagnosis, again 12-lead ECG and vagal maneuvers are recommended. This is the modified Valsalva maneuver, where a 12-lead ECG should be done. Then if SVT is confirmed, we should ask the patient to blow for about 15 seconds in a syringe of about 10 milliliter, then for 15 seconds, then elevate the limb 45 degrees for 15 seconds, then again in recumbent position for another 30 seconds. Usually it's very successful in termination of SVT from the first or the second, and in some cases from the third time if done correctly. This is the effect of adenosine on SVT, supraventricular tachycardia management. Sometimes there is no effect, so possibly it could be high septal VT or inadequate dose. Sometimes gradual slowing, then reacceleration, like in sinus tachycardia and automatic focal atrial tachycardia. Sudden termination as in AVNRT, AVRT, and sinus node reentrant tachycardia, and sometimes persisting atrial tachycardia with transient AV block like an atrial flutter. So this is sinus tachycardia, and if it is incessant sinus tachycardia, which is all the day, we can give beta blockers or ivabradine or both together according to the guidelines if not controlled. In atrial tachycardia, we can still use beta blockers in acute situation, and in chronic we can use beta blockers or calcium channel blockers. In cases of atrial flutter with fixed AV conduction, anticoagulation is important, and medical treatment including beta blockers or calcium channel blockers or catheter ablation in isthmus-dependent atrial flutter. In junctional tachycardia, medical treatment includes beta blockers, calcium channel blockers, and in some selected cases, if incessant junctional tachycardia, catheter ablation is class 2P. In cases of AV nodal reentrant tachycardia, as you see here, vagal maneuvers if the patient is hemodynamically stable. If patient is not hemodynamically stable, we can use synchronized DC cardioversion. Medically, we can use IV adenosine or beta blockers or verapamil. And ablation, of course, in symptomatic patients not controlled on medical treatment. It's important that amiodarone, sotalol, flecainide, propafenone are not mentioned in management of AVNRT in 2019. So calcium channel blockers, beta blockers, or ablation in cases that not responded to medical treatment. What about AVRT, where there is accessory pathway, as you know? Again, if the patient is not hemodynamically stable, we can use synchronized cardioversion. If the patient is hemodynamically stable, we can start with vagal maneuvers. If responsive, that's fine. If not, we can use IV adenosine. If good response is fine. If not, we can use calcium channel blockers or beta blockers. This is an acute situation. Then catheter ablation is class 1B indication for patients with AV reentrant tachycardia, as you see in this diagram. What not to do in patients with AVRT is to use flecainide or propafenone is class 2P, while beta blockers is class 2A, and it's worth mentioning that amiodarone again is not indicated in AV reentrant tachycardia. So what about asymptomatic preexcitation? Individuals with asymptomatic preexcitation, they should be screened for with ECG, echo, and Holter ECG. And if there is criteria of high-risky patients like presence of intermittent atrial fibrillation or positive family history, or they are working in stressful jobs like fighters or air pilots, we can go for EP study to detect the inducibility of AV reentrant tachycardia. If positive, we can still use catheter ablation. Of course, in presence of atrial fibrillation and accessory pathway, we should do catheter ablation in chronic patients, while in acute situation we have to do synchronized cardioversion. What about atrial fibrillation? Atrial fibrillation, it's very important to convert the patient to sinus rhythm, keep the patient in normal sinus rhythm, control of ventricular rate, and preventing thromboembolic disease. Those are the four main management issues of management of atrial fibrillation, as you see in this diagram. What about supraventricular tachycardia management in pregnancy? So acute therapy, immediate DC shock, vagal maneuvers, both are safe. IV beta-1 selective beta blockers could be if option number 1 or 2, which are vagal maneuvers or cardioversion, are not available. While during the first trimester of pregnancy, it's recommended that all antiarrhythmic drugs should be avoided if possible. It's very important. If you have to, you can give beta-1 selective except atenolol, beta blockers, or verapamil if the patient had recurrent bouts of SVT. Catheter ablation is recommended in patients with tachycardiomyopathy due to supraventricular tachycardia. We can still use beta blockers for those patients to reduce the ventricular rate. What about the supraventricular tachycardia and sports participation? Possibly this is the last slide. Premature atrial peaks, they can engage in all sports. AVRT or AF in the context of WBW ablation first, then they could do all sports. Asymptomatic pre-excitation ablation, then they could do all sports. Paroxysmal SVT, they should be treated medically or by ablation, then they are omitted to do all sports. Ablation, if not feasible or not desirable, high intrinsic risk of loss of consciousness or very high competitive sport, they shouldn't be allowed to do those types of sports. Thank you very much and have a good day.